Welcome to Season 4 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Commissioner of Health in Baltimore City. Our goal is to bring scientific evidence and experience to current topics in public health through engaging interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Stephanie Desmond talks to Sika Yeboah Sampong, a lawyer with the Legal Action Center, who recently co-authored a report about how emergency departments can provide life-saving care for people with substance use disorders, and also how emergency departments may be violating multiple federal laws if they do not provide that care. Let's listen.
Sika Yeboah Sampong, thanks so much for joining me.
Thanks so much for having me today.
Now, you work with the Legal Action Center, a nonprofit, and you recently co-authored a report about emergency departments and hospitals and the potential legal liability they have for how they treat substance use disorder patients. And I'm wondering if you could just sort of give me a real quick overview of what the issue is at hand.
Sure. Thanks so much. So really the issue that our report is addressing is what kind of potential legal liability there may be when emergency rooms are presented with folks who have substance use-related conditions, so perhaps overdoses or skin infections due to injection drug use, and what legal liability is triggered when they don't actually provide evidence-based practices for substance use disorder and instead really focus on the acute treatment of the aspects of substance use disorder or the presenting emergency. And so what our report does is really lay out the current factual landscape as far as what many emergency rooms are doing as far as this treatment. And then we identify 3 evidence-based practices that some emergency rooms do provide, and that we hope all emergency rooms will provide in order to avoid this legal liability. And then we assess the legal liability under 4 key federal laws. So we looked at liability under EMTALA, the Emergency Medical Treatment and Labor Act. And we also looked at liability under 3 anti-discrimination laws. So the Americans with Disabilities Act and the Rehabilitation Act, and also Title VI of the Civil Rights Act.
So what should ERs be doing when someone comes to them with a substance-related issue?
You know, it's a great question. And the very simple answer is they should be doing their job, right? And so for an emergency room, their key role is the identification of life-threatening medical conditions. And so for someone with a substance use-related condition, what it looks like for the emergency room to do their job is to first screen them for substance use disorder and also to conduct a diagnostic assessment for substance use disorder using criteria from the DSM-5 to see whether they have a substance use disorder. And then as a second step, it also requires the emergency room to offer to administer buprenorphine, a medication for opioid use disorder, if the patient has an untreated opioid use disorder or is in opioid withdrawal. And then as a third step, it also requires the emergency room to connect that patient vis-a-vis a facilitated referral to ongoing substance use disorder care. And prior to discharge, if the patient is someone who uses opioids or who uses substances that can be mixed with opioids, so for instance, cocaine, which can be mixed with fentanyl, a synthetic opioid, to also provide them with naloxone at discharge to make sure that they have the overdose reversal drug as well at their disposal.
Explain for our audience what buprenorphine does.
Sure. So buprenorphine is an opioid agonist medication, and it's one of 3 FDA-approved medications to treat opioid use disorders. So there's methadone, naltrexone, and buprenorphine. Buprenorphine is really the most feasible for emergency department administration. And what it does is it helps to really manage someone's opioid withdrawal symptoms. It also helps to suppress opioid cravings. So what you see oftentimes when people leave the emergency department is, one of the emergency department doctors we spoke to talked to us about how sometimes someone will be discharged and they'll begin using again in the car park of the emergency department. And so buprenorphine is something that helps to curb and suppress those cravings to use, and also helps to kind of manage just the symptoms of opioid withdrawal, which, if untreated, can also become really dangerous for that person's health.
So these seem like fairly simple steps that need to be taken. Why aren't some emergency rooms doing this?
That is the million-dollar question. And that was a question we continued to ask ourselves really throughout the course of the report. And what we found was, I think there's a multi-layered answer, but at the core is really stigma. And so stigma isn't kind of just this abstract thing. It's something that's very real, especially in the healthcare field when it comes to treatment of people with substance use disorders and folks who use substances. And it seeps into every aspect of care. So, for example, when we were researching for our report, we found a survey that found that about, I think it was more than a third. So I think almost 40% of hospitalists actually said, substance use disorder isn't like the other medical conditions, because these are folks who are choosing to be sick. They're choosing to use these substances. So their condition is kind of different. They're not as deserving of care as someone who has, say, diabetes or hypertension. And it was interesting because in that same survey, they found that over 10% of those same physicians actually felt that substance use disorder should be a criminalized condition, which we know in very real ways it is. And so when you have data like that and that kind of really prevalent stigma in not just in the healthcare field, but in the emergency room where folks are supposed to be receiving care in their moment of crisis, it really does trickle down into these ideas that these are difficult patients to treat. These are undeserving patients. These patients don't actually want to get better, but they require all this time and resources. And so I think that's a huge part of why we haven't seen kind of wholesale adoption of these practices. I think another reason is oftentimes emergency rooms and hospitals more generally will talk about their concerns about safety. So they'll say, an emergency department physician doesn't have the skills to kind of handle the healthcare needs of someone with a substance use disorder or someone with a substance use related emergency, because these folks may have comorbidities or they may have been recently revived with naloxone, in which case they're not appropriate for immediate administration of buprenorphine. And we also hear kind of justifications as far as the emergency room is already very stretched thin. And they have limited resources, which is true. I mean, especially in the midst of the COVID pandemic, we've seen that. We know that's the case. And it's resources in a number of meanings. So it's human resources as far as, even if we were to adopt these practices, where would we send these patients if we give them a facilitated referral? There's a shortage of kind of community-based substance use disorder treatment facilities and resources to send folks to. But when we looked at the research, we actually found that a lot of times emergency departments kind of underestimate how many resources are available in the community. And so they assume there aren't many. And because of that, they don't necessarily do this kind of warm handoff to care. But what we read is that oftentimes when emergency rooms start to look into what resources are available, they're more available than they thought, right? So it's not to say that it's not an issue, that there aren't enough community-based resources and treatment options, but they're probably more than the hospital assumes. And then we also have heard this kind of refrain of, we have limited financial resources as well. So there are actually laws on the books in some states where insurers won't pay for services or treatments that are required because someone sustained an injury while quote unquote intoxicated. And so that kind of also has a chilling effect on emergency rooms diagnosing, naming substance use disorder, because they want to make sure they're being paid for the services they provide. But I mean, all of these things connect back to stigma. So stigma is kind of oozing into all of these places. And none of these is a real legal justification not to provide these services.
So I want to remind our listeners that the addiction and overdose crisis has not gone away in the pandemic. It has accelerated. More than 92,000 people in the U.S. died of overdose basically in the last year. So it's important to get folks treated, more important than ever before. So in layman's terms, why are these hospitals, emergency rooms in legal jeopardy if they don't start referring for treatment, giving buprenorphine, et cetera?
Yeah, that's a great question. So in a layperson's terms, really it's because to fail to do so, to fail to offer these 3 evidence-based practices that we've identified is for the emergency room to fail to do its job, right? And I know I've said that before, but it's a point I really want to drive home because what we are saying the emergency room needs to do and what the law says the emergency room needs to do for this patient population isn't so different from what the emergency room does for other people with other medical conditions, right? And oftentimes also people with substance use related conditions have other medical conditions. So the same care you would get if you're, say, asthmatic and you go to the ER and you're given an inhaler and you're connected with a pulmonologist, it should be no different for someone who has a substance use related condition. They come in, they're given buprenorphine. If they have an opioid use disorder, they're given naloxone as a harm reduction practice, and they're connected to the correct kind of specialized services that they need as well.
And these referrals, for example, are really life-saving. I mean, I saw you had an example in your report. I don't know if you want to talk about that.
Sure. So we reviewed a ton of different studies and research for our report. And one of the examples, and maybe this is the one you're referring to, is there was a hospital in California. Their emergency room implemented facilitated referrals, these warm handoffs from the emergency room. And I think they had I believe it was more than 90% of folks showed up for these follow-up appointments once you have a warm handoff, which makes sense, right? Like instead of giving someone a sheet of paper with a ton of numbers on them for programs that may or may not be open, that may or may not accept their insurance, that may or may not have someone who speaks their language, just those kinds of really basic pieces of information you need to really make sure that continuum of care isn't broken. When you kind of fish out that information for the patient proactively, when you call the patient to check up and make sure they made it to their appointment, when you make sure that they have transportation for their appointment, people will go. It's not a question of people not wanting to go. Oftentimes it's just the myriad of barriers that can be the difference between someone like having a sheet of paper and going to their appointment, or it just kind of being lost in a sea of other paper and just a sea of other demands in someone's life.
And I think that the result was that more than 70% of those folks were in treatment a year after their emergency room visit.
Exactly. So it has these really great outcomes for treatment retention as well. And that's a huge part of what we want to see.
And my last question, we're running out of time, is that not everybody wants to be treated for their substance use disorder. So talk me through that.
Yeah, that's a really good point. And that's why we make a point throughout our report to talk about, for example, the offer to administer buprenorphine. We're not saying that the emergency room can force someone to take buprenorphine, but we're saying that the patient needs to be given that option, right? And so what our report focuses on is what the emergency department must do, what the emergency department's duties are. It's always up to the patient to decide whether or not they want to engage or take the emergency room up on that offer. But our key message is that the offer needs to be made, and then you leave it up to the patient to make the decision about their health care.
Sika, thank you so much for joining me.
Thank you. This was a pleasure.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.